3 of the 5 medications I'm about to share with you require no prescription whatsoever. You can walk into any pharmacy right now and purchase them directly off the shelf. That is precisely what makes them so dangerous for anyone who has crossed the threshold of 60, because when something is that easy to obtain, we stop treating it like a drug. We treat it like it's completely harmless. And for a body that has reached 60, that assumption can mean the difference between living independently and ending up in a hospital bed. Here is something most physicians never explain clearly enough during a 15-minute appointment. The human body processes medications in a fundamentally different way after 60. Your kidneys filter drugs out of your bloodstream far more slowly. Your liver metabolizes compounds at a fraction of the speed it managed 20 years ago. Your brain becomes dramatically more sensitive to sedatives and anticholinergic compounds. A dose that was perfectly safe for you at 45 can now cause falls, memory impairment, kidney damage, and cognitive decline that gets mistaken for the early stages of Alzheimer's disease. Today, I'm walking you through 5 specific medications that illustrate this problem more clearly than any others, and all 5 appear on the American Geriatric Society's Beers criteria, the medically reviewed, regularly updated list of drugs considered potentially inappropriate for older adults. This isn't fringe medicine or alternative health advice. It is mainstream geriatrics finally reaching the people who need it most. I'm Dr. Richard Holloway, and this channel is entirely dedicated to translating current research into practical, actionable information for adults over 60. If you haven't subscribed yet, please take a moment to do so, because we publish new evidence-based content every single week designed specifically for you. Now, let's get into these 5 medications and, more importantly, what to do if you or someone you love is currently taking any of them. The first category is benzodiazepines. You probably recognize the brand names more readily than the drug class itself: Xanax, Valium, Ativan, Klonopin. These are prescribed primarily for anxiety and insomnia, and they do work in the short term. That effectiveness is part of why they're so widely used, and it's also part of why they're so consistently problematic for older adults. After 60, the brain's sensitivity to benzodiazepines changes significantly. Because the liver metabolizes these drugs more slowly, they accumulate in the system. A dose meant to help you sleep at 10 in the evening may still be impairing your coordination when you get up at 3 in the morning for a glass of water. Multiple systematic reviews confirm that benzodiazepine use is associated with a substantially elevated risk of injurious falls in older adults, falls serious enough to require hospitalization. Falls are the leading cause of fatal injury in adults over 65 in the United States, so we are not talking about a minor side effect here. And beyond the fall risk, benzodiazepines consistently impair memory, attention, and executive function in older adults, even in people who feel they've fully adapted to the medication. The American Geriatric Society explicitly lists the entire benzodiazepine class on the Beers criteria as drugs to avoid in older people. If you are currently prescribed Xanax, Ativan, or Valium, please do not stop taking it suddenly. Abrupt discontinuation can cause serious withdrawal effects, including seizures. This is a conversation you need to have with your doctor about a supervised gradual taper, and I'll tell you exactly what to bring to that appointment in just a few minutes. Comment below right now. Are you or someone in your family currently taking any of the medications I've mentioned or will mention? I genuinely want to see how widespread this actually is. The second medication on this list shocks people every time I bring it up, partly because it costs about $6 at any drugstore: diphenhydramine, sold as Benadryl for allergies and as the active sleep ingredient in ZZ-Quil, Unisom, and Tylenol PM. Millions of older adults take this every single night, fully confident that because it's available without a prescription, it must be safe. It isn't. Not after 60. Diphenhydramine is one of the most potent anticholinergic drugs available over the counter. Anticholinergic means it blocks acetylcholine, the primary neurotransmitter your brain relies on for memory and learning. Interfere with that chemical nightly for months or years, and the consequences become genuinely serious. A landmark prospective cohort study published in JAMA Internal Medicine in 2015 followed 3,434 adults aged 65 and older for over 7 years. Researchers identified a clear dose-response relationship between cumulative anticholinergic drug use and dementia risk. Those in the highest use category showed a 54% increased risk of developing dementia compared to non-users, and the most common anticholinergic drugs in that study were first-generation antihistamines, exactly like diphenhydramine. A 2019 study published in JAMA Internal Medicine, examining nearly 60,000 dementia patients, corroborated those findings, and the evidence has continued to build every year since. I had a patient, a woman of 71, who had been taking 2 Benadryl tablets every night for nearly 5 years. Her own doctor had actually suggested it for sleep. Over those years, her family watched her become increasingly forgetful. Repeated questions, confusion in familiar places, words lost mid-sentence. A geriatric medication review flagged the diphenhydramine immediately. Over the following 7 months after she stopped taking it under medical guidance, her cognitive test scores stabilized and partially improved. Her daughter described it as getting a piece of her mother back. The change was unmistakable. The third medication is one that tens of millions of older adults reach for the moment their knees or back start to flare, and the kidney damage it causes develops silently, without a single symptom, until it is already well advanced. Ibuprofen and naproxen, sold as Advil, Motrin, and Aleve. These non-steroidal, anti-inflammatory drugs are the first response to pain in most households, and for occasional use in younger adults, they're generally manageable. For regular use in adults over 60, the risk profile changes entirely. Your kidneys are responsible for filtering these drugs from your bloodstream, and after 60, kidney function has typically declined by 40 to 50% compared to young adulthood. When ibuprofen circulates in a body with already reduced kidney function, it lingers far longer, hits far harder, and progressively damages the very tissue responsible for clearing it. The 2023 update to the American Geriatric Society Beers criteria specifically reinforced the need for renal function-based dose adjustments for NSAIDs, recognizing how frequently this class causes acute kidney injury in older adults. The gastrointestinal risk is equally serious. The stomach lining becomes more fragile with age, and NSAIDs directly impair its protective barrier. According to the NIH, older adults who use NSAIDs regularly are 3 to 5 times more likely to develop a serious gastrointestinal bleed than younger users, and those bleeds are far more dangerous in someone over 60. For anyone managing heart disease or high blood pressure, NSAIDs additionally raise blood pressure and increase fluid retention, elevating heart failure risk considerably. This is the trifecta that makes ibuprofen and naproxen particularly hazardous as a daily or near-daily habit after 60. Tell me in the comments, do you currently use ibuprofen or naproxen for pain? Comment yes or no below, because I'm going to tell you what works significantly better for joint pain in older adults without any of these risks. The fourth medication is prescribed to roughly 10 million Americans annually for sleep. Zolpidem, sold as Ambien. The FDA issued a specific safety communication about this drug and older adults, noting that elderly patients can have far higher blood concentrations of zolpidem the morning after taking it, compared to younger users taking the exact same dose. This means they are still pharmacologically sedated when they wake up without being the slightest bit aware of it. They feel like themselves. They don't feel impaired, but their coordination and reaction time are genuinely compromised. Research consistently finds that zolpidem use is associated with nearly twice the risk of hip fracture in older adults. Hip fractures in adults over 60 carry a 1-year mortality rate of 20 to 30%, meaning up to 3 in 10 seniors who break a hip may not survive to the following year, often due to complications like blood clots or pneumonia during recovery. There is an additional problem as well. Zolpidem suppresses the deep restorative stages of sleep while increasing lighter sleep stages, so you fall asleep faster but wake up feeling less restored, which drives continued use, higher doses, and dependency. It solves nothing. It simply changes the shape of the problem. The fifth medication surprises more people than any other on this list: proton pump inhibitors, omeprazole, Prilosec, Nexium, Prevacid. These are among the most widely prescribed drugs in the world, and for short-term use of 4 to 8 weeks, they are appropriate and effective for acid reflux and stomach ulcers. The problem is that most older adults aren't taking them for 8 weeks. They've been on them for years, sometimes decades, with no reassessment whatsoever. Long-term PPI use after 60 quietly depletes 2 critical nutrients. First, vitamin B12. Your stomach acid is essential for absorbing B12 from food, and suppressing that acid for years causes B12 absorption to drop sharply. Research published in JAMA found that long-term PPI use was associated with a 65% higher risk of B12 deficiency. In older adults, severe B12 deficiency causes peripheral neuropathy, the tingling and numbness in the hands and feet, as well as cognitive decline that closely mimics dementia. Second, magnesium. The FDA issued a specific safety communication warning about hypomagnesemia, meaning dangerously low magnesium levels in long-term PPI users. Low magnesium affects heart rhythm and nerve signaling in ways that compound other cardiac and neurological risks in older adults significantly. I treated a patient, 76 years old, who had been on omeprazole for 9 years, originally prescribed for an ulcer that had resolved long before he ever came to see me. He had been living with severe foot numbness and what his family described as a mental fog he simply couldn't shake. His B12 came back critically low. I tapered him off the PPI over 8 weeks, initiated aggressive B12 replacement therapy, and shifted his reflux management to dietary modifications and a safer alternative medication. 4 months later, his neurological symptoms were clearly and measurably improving. 9 years on a prescription that was no longer necessary, caught with a single thorough medication review. Here is exactly what I want you to do after watching this. First, write down every medication you take, prescription and over-the-counter alike. And yes, that includes the Benadryl, the Advil, and the Prilosec, because over-the-counter does not mean safe. Second, bring that list to your doctor and ask specifically for a geriatric medication review, requesting evaluation against the American Geriatric Society Beers criteria. Those exact words will be immediately recognized by any qualified physician. Third, for pain management, ask your doctor about acetaminophen as a first-line alternative. It is significantly safer for the kidneys and gastrointestinal tract in older adults at the correct dose, which is no more than 3,000 milligrams total per day for adults over 65. Fourth, for sleep difficulties, ask for a referral to cognitive behavioral therapy for insomnia, known as CBTI. Studies consistently show it outperforms every sleep medication available for long-term outcomes, with 0 drug interactions, 0 dependency risk, and no morning impairment whatsoever. Fifth, if you've been on a proton pump inhibitor for more than 6 months, ask your doctor whether you still genuinely need it and whether your B12 level has been checked recently. A critical safety note before we close: do not stop any prescription medication without speaking to your doctor first. Benzodiazepine withdrawal without proper medical supervision can cause life-threatening seizures, and for anyone managing heart disease, kidney disease, or multiple prescriptions simultaneously, any medication change requires careful, coordinated medical oversight. These 5 medications are not automatically dangerous for every person in every situation, but in adults over 60, used long-term without reassessment, the research is entirely consistent. Your body has changed since you first started taking some of these drugs. Your medication list may need to catch up with that reality. Leave a comment below with one of 3 things. Comment reviewing my list if you're going to check your medications today. Comment your age and which of these 5 you plan to ask your doctor about. Or comment sharing this if you're sending it to a parent or loved one who needs to see it. Please subscribe, because next week I'm covering 5 supplement combinations that are quietly dangerous for older adults, including combinations being marketed and sold together in the same bottle as though they are perfectly safe. That video could genuinely protect someone you care about. I'm Dr. Richard Holloway, and I'll see you next week.